Okay, so good afternoon. We'll begin, and the only thing I would mention for those of you who haven't been to one of these sessions, we encourage you to ask questions, interrupt in the middle of a talk, but there'll be time at the end of each and at the final. The one thing I would ask is just wait until we can get a microphone to you, because there are lots and lots of people, between 200 and 400, believe it or not, each week, who download this here on the NIH campus. And they send me emails saying, we often hear the answers, but we don't know what the questions are sometimes. So it's just be a little bit patient. And the other thing I mention is, recall I pointed out that the schedule had changed. And so next week, is the oral microbiome meets cell biology and periodontal disease. It's incredibly exciting work, and I hope all of you will come. So let's see. You haven't been here before. So what is this picture?
It's a suspension bridge.
Right. Anybody know what it is? What is it? Sure, it's the Brooklyn Bridge. So why do we show the Brooklyn Bridge? Because it's a wonderful advertisement for the purpose of this whole course, which is to bridge two things. One, the incredible advances in basic biological and engineering sciences, and the other is with disease mechanisms, treatment, understanding, and so forth. And that's one of the big gaps that exists in medicine and science today. So this course is one small step, because most of the people who attend either here or online are Ph.D. scientists who know relatively little about disease and disease mechanisms, but a great deal about reductionist science in one form or another. So just for the record, that's Manhattan on the other side, and this is Brooklyn. And those gentlemen and ladies could walk out on the catwalk. So that's where we're going today. We're going to walk out on the catwalk once again of congenital heart disease this time. And so the purpose is to excite you about exciting things that are going on. This is not intended to be like a medical school or even graduate school lecture where people are supposed to take copious notes and memorize a lot. For those who come to at least 50% of the things and sign in and take a very, very difficult, I assure you it's not, electronic exam at the end, you get a certificate from the NIH for having taken this course in demystifying medicine. And that will guarantee a job for you after your postdoctoral fellowship. So, okay. Today we're going to, okay, so very quickly, because I think today's subject is really one of the great advances in medicine. And you can sort of divide it into roughly, this is the way a liver doctor would divide it into anyway, into the beating heart era, when surgery was done on the beating heart, beginning in a breathtaking performance in Boston in 1938. And then probably the most famous woman in American medicine, Helen Taussig, who I believe was the first woman professor at Johns Hopkins School of Medicine. She may be the only professor, I'm not sure about that, but she was certainly the first, and she was an amazing lady. And then came the era when you could quiet the heart by generating techniques to bypass. In other words, operate on a heart that wasn't actually beating. And that initially was cross-circulation, and then machines were developed. And then the era that began with Cournot and the Nobel Prize in the 1930s of being able to catheterize the heart and measure blood supply and everything else. Surgical advances, including transplantation and other techniques. And then here we are in what I would call the brave new era, which is the bridging of genomics, development of pharmacologic approaches to treatment of congenital heart disease and other disease, the incredible input of bioengineering, which you'll hear about from Bob Lederman, and even the possibilities of considering surgery in a fetus. But these things are things that will be presented and hopefully, stimulate your interest. So our first speaker is Gail Pearson, who graduated from Johns Hopkins in medicine and also has a Doctor of Science degree in public health policy. She's a pediatric cardiologist who I believe recently came to NIH in your new position, right? As Associate Director of the Division of Cardiovascular Sciences, and she's also Director of the Adult and Pediatric Cardiac Research Program at the NHLBI. Well, Dr. Pearson has extensive experience in research and in clinical aspects of congenital heart disease, and so she's going to speak first. And then she'll be followed by Bob Lederman, who trained at Western Reserve School of Medicine and received training in adult cardiology in San Francisco, went to the University of Michigan, got interested in interventive, non-surgical intervention type of technology and biology, and was at Michigan, then at Duke, back at Michigan, and came to the Heart Institute here in 2000 to begin work on interventional cardiovascular MRI and other technologies. So Bob's interest is to expand the capability, the safety, the effectiveness of ways of non-operatively dealing with real-time imaging, and also set the basis for interventive surgery, correction of congenital defects, and other possibilities. So, Gail, would you begin, please?
Thank you. Can people hear me? I just turned on my mic. I'm delighted to have the opportunity to be here this afternoon, along with my colleague Laura Olivieri, who will be here. She's stuck in traffic and is about 15 or 20 minutes away, so she'll be just in time, actually. So we're here today to demystify congenital heart disease for you. I have no disclosures. So I want to start off with a quiz. Everybody has to participate. Which one of these young people has a birth defect? How many think the child in A has a birth defect? Okay. How about B? Okay. C? Okay. All right. Well, the answer is, for those of you who didn't raise your hands, they all have a birth defect. The first child has Down syndrome. She may also have heart disease. About 50% of children with Down syndrome have heart disease. Mackenzie Klein, who's an amateur golfer, has complex congenital heart disease, as does Shaun White, who's an Olympic gold medal snowboarder. Now, a lot of you didn't raise your hands, and why don't we think of this as a birth defect? Well, the reason is that we think of a birth defect as something we can see. So we could see that the first child has perhaps some unusual facial features and other features, and that may be associated with a birth defect. But we don't think of heart disease as a birth defect. In fact, most children are healthy. And when we think of a childhood disease, we typically think of children with cancer, the little bald kid in the baseball cap. But in fact, congenital heart disease is about 3 times more common in children every year than pediatric cancer. And part of the purpose of this talk is to increase your awareness, because every 15 minutes, a baby's born with a congenital heart defect. So this afternoon, there'll be quite a few babies born during this talk who have a congenital heart defect. So how does the heart form? Well, the heart's the earliest organ to form. It's pretty much formed by 8 or 9 weeks of gestation before many women realize they're pregnant. And so it starts out as a couple of groups of cells on 2 sides of the embryonic disc. It coalesces into this sort of double horseshoe, and then further coalesces into this symmetric tube. And that's the last time the left side of the heart looks like the right side of the heart. And over time, through a combination of molecular signaling and mechanical factors and differential cell growth and cell death, it goes from this sort of primitive form of the heart here to this final mature form of the heart with 4 chambers. The 2 top chambers are called atria. The 2 bottom chambers are ventricles. There's a wall or a septum between the 2 sets of chambers. There's 4 valves and major arteries that come off of the heart that feed the lungs and the body. And so this goes right about 99% of the time, which actually sort of amazes me if you look at the slide and think about what's going on here and the short amount of time in which it happens. And then the 1% of the time that it doesn't go right, we call that congenital heart disease. So congenital means something you're born with. So what's the spectrum of congenital heart disease? It's not just one thing. In fact, even if you're a lumper and not a splitter, it's about 35 different things. There are various types of congenital heart disease that can range from the fairly simple shown here. So here's our normal heart. 2 of the most common things we see are defects in either the atrial septum between the 2 top chambers of the heart or the ventricular septum between the 2 bottom chambers of the heart. Where a lot of the attention is, even though it's more rare, is in complex congenital heart disease. This is where most of the action is in pediatric cardiology. So here's Mackenzie Klein again, our golfer. She was born with something called hypoplastic left heart syndrome. The left side of her heart did not show up. It didn't form during embryonic development. And she's playing golf now after 3 surgeries, the first one which would have happened in the first week of her life. And then here's Sean White. He was born with tetralogy of Fallot. This is the classic sort of blue baby cardiac defects. I want you to remember that because we're going to talk about it a little later. Here he's got 2 ventricles, but he's got this giant hole between the 2 ventricles. And because of rearrangements in muscle tissue underneath the pulmonary artery, he's got obstruction to blood flow out his pulmonary artery. So he's not getting enough blood to the lungs to get enough oxygen, so he's blue. And this would have required either 1 or 2 procedures surgical procedures in the first year of life. And I just want to take a brief side trip in history. This slide fascinates me. The State Museum of Detmold, Germany has a large mummy collection, and then there's this one small mummy here. And they are assessing the mummies using modern imaging techniques. And so when they scanned this one with the CT scan, which you see here, they found out that the left ventricle was missing in this child. There's this little slit here where there would have been a left ventricle. This is the right ventricle, which is normal size, the right atrium. And then in the 3D reconstruction, you can see the same thing here. Left ventricle's tiny. There's this little teensy aorta here. This is what Mackenzie Klein had. And so you can see that congenital heart disease is not new. So I didn't bring a patient today. It's hard to bring a child on a school day. But I would like you to meet Joshua Orme. Joshua wishes he could be here today. He sends his regards. Joshua was born in December of 2000. He was a normal weight, full term, born after an uncomplicated C-section. And after that, things got really interesting. At first, the doctors were focused on his cleft lip and palate and his right arm. You can't really see here, he's undergone repair of the cleft lip and palate. Our plastic surgeon said it was the worst one he'd ever seen. This itself required a couple of surgeries. And he doesn't just have his hand in his pocket here, his right arm ends here. So as you might imagine, people were fairly focused on stabilizing this child. And by 1 day of age, he was not feeding well, he was breathing fast, he was placed on oxygen, and he was transferred to Children's where I met him. He arrived on my service. I see patients at Children's in addition to my activities here at NHLBI. So how did we find out what Joshua had? The main way we do diagnosis in congenital heart disease is with echocardiography. This uses ultrasound. There's no ionizing radiation. You bring the ultrasound machine right to the child's bedside, and with this little transducer, you scan through various imaging planes in the heart. It's a three-dimensional structure. You're trying to recreate it with two-dimensional imaging, at least in this technique. And at the end of the echocardiogram, we have a complete picture of the heart. And in Joshua's case, so this was 15 or so years ago. Today, Joshua's mother's obstetrician would have probably picked up that something was wrong with the baby's heart on an obstetrical ultrasound, and then she would have undergone a fetal echocardiogram. So we can look at the fetal heart starting as early as 12 to 15 weeks. And in addition, since 2011, there's been a national push for screening for critical congenital heart disease as part of standard newborn screening. So this is done with sensors on one hand and one foot that measure oxygenation in the blood, and if the oxygenation level is too low or there's a difference between the upper and lower extremity, then additional testing is warranted. So what did Joshua have? Here's a normal heart, and I want you to focus on this valve, which is the tricuspid valve on the right side of the heart between the right atrium and the right ventricle. So Joshua's echo looked something like this. This is the left ventricle. And as you can see, there are two leaflets to this mitral valve on the left side of the heart, but there's kind of this plate of tissue here. And so what Joshua had is known as tricuspid atresia. That means the tricuspid valve didn't form, which also means that the right ventricle didn't form properly. And he's got this septal defect here between his left ventricle and this little rudimentary chamber where blood flows to the pulmonary artery. So this is not a good thing. So how did this happen? So you remember this diagram of how the heart forms. Somewhere between this stage, when the atrioventricular valves are forming, these are the mitral and tricuspid valves, or they will become the mitral and tricuspid valves. Something went wrong here, and the tricuspid valve didn't form properly, and as a result, the septum that should have formed between the left ventricle and right ventricle also didn't form completely, and the right ventricle also didn't form. So we did not get the normal heart on this occasion. Why does Joshua have congenital heart disease? Roughly a third of congenital heart disease has a genetic cause. Mostly we're finding out now these are de novo mutations, although there is some familial congenital heart disease. There are also maternal and paternal factors. Yes, it's not always the mother's fault. That are associated with an increased risk of congenital heart disease. Also, if you've had a child before with congenital heart disease, your risk goes up from 1%, which is sort of the baseline, to maybe 5 to 10% or even higher, depending on the type of congenital heart disease. So Joshua's mother, with her subsequent pregnancy, would have had a fetal echocardiogram. Twins, for some reason, being pregnant with twins increases your risk of congenital heart disease. But mostly, and this is the case with Joshua, it's unclear. We haven't done sophisticated genetic testing on Joshua, but his chromosomes are normal based on karyotyping that was done at birth. So when the year Joshua was born, he joined 40,000 other newborns in the United States who were born with congenital heart disease. And he was also one of about 10,000 who have critical congenital heart disease. This is defined as a condition, part of the spectrum that requires intervention either immediately or sometime within the first year of life. He's now among roughly 1 million children living with congenital heart disease, and in a couple of years when he turns 18, he'll join the more than 1 million adults who have congenital heart disease. Because of improved survival over the years, people are now living well into adulthood. Tricuspid atresia is among the rarest of these rare congenital heart conditions. It's about 1% of all congenital heart disease. and it was first reported roughly 200 years ago. There's a slight male preponderance for tricuspid atresia, no racial or ethnic differences that we know of. In general, across congenital heart disease, the gender and racial and ethnic variables vary by the condition, but overall there aren't many differences. Sadly, of course, and unfortunately, outcomes tend to be different and worse for non-white children, something we are working on. I would also note, I mentioned Joshua's other anomalies. Roughly 30% of children with congenital heart disease also have additional what we call extracardiac anomalies. So Joshua's treatment was largely surgical and interventional. And this is really the mainstay in congenital heart disease. It's a structural problem. We need a structural solution or solutions. Children with heart disease certainly take medications, but they're not the mainstay of therapy for the most part. So he had, by the time he went to kindergarten, he had 3 heart surgeries and 3 cardiac catheterizations and another cardiac catheterization before his 10th birthday. So for those of you who don't know, this is a simple cartoon of a cardiac catheterization using the large blood vessels that are near the surface in the groin. 1 or more catheters is inserted up into the heart, where pressure measurements can be taken, measures of how well the heart is performing are taken, and interventions can also be done. Balloons can be used to open up blockages, open up narrowed valves, and devices can be used to close things like the atrial septal defects and ventricular septal defects that I mentioned to you a little while ago. So this is the part of congenital heart disease that we refer to as the plumbing aspect. We reconnect abnormal connections, we relieve blockages, and we correct leaks. Joshua also needed a pacemaker when he was about 14 years old. In many cases, this can be done with a cardiac catheterization, but in his case, because of his heart, this required another open heart surgery, an incision in his sternum, his 4th one for him. Now, the electrical part of the heart goes along with the plumbing part of the heart. It's the electricity or tiny electrical communications between cells along a specialized network that allows the heart to beat. And Joshua's heart just was beating too slowly for him. He was fatigued with exercise, and so he had a pacemaker put in last year, and he's doing much better now. Along with these surgeries, he and his mom have come to see me quite a few times, and he's had multiple surgeries for his cleft lip and palate. And just remember, he's only 15. Okay, surgery number 1. These are Joshua's actual cardiac catheterization diagrams. So these were done after the surgery, and in some cases, cardiac catheterization is done to help plan for the surgery. So when he was 13 days old, he had a band placed on his main pulmonary artery here, and that was because this hole was so big and there was blood being pumped to his pulmonary arteries under high pressure from the left ventricle, and so he was getting too much blood flow to his lungs and was having trouble breathing. Now I want you to focus on this area because on the next surgery, he had the superior vena cava, the main vein that drains blood from the head and neck, connected directly to the right pulmonary artery. Now remember that band, he's got a little kink here now. So before this surgery in a cardiac catheterization procedure, a catheter was advanced to this position, a balloon was blown up, and this little stent, which is like a little fence that keeps the artery open, was placed. So that was the connection, that's the catheterization. And then again, I want you to focus on this because his next surgery at age 3.5 years now connects both great veins, the inferior vena cava and the superior vena cava, directly to his pulmonary artery. Now keep in mind that in most of us in this room, or I'm assuming most of us in this room, we've got a ventricle over here that's pumping blood to the pulmonary artery. That is not the case in Joshua. It's not the case in any child who's born with single ventricle physiology. We don't yet create a second ventricle. The blood flows across the pulmonary circulation through changes in intrathoracic pressure due to breathing and other forces. So how do we get started with congenital heart surgery? I was glad that Dr. Arias just introduced this. I did want to just say one thing about Robert Gross, the ductal ligation in 1938. He was a resident then. He'd been proposing doing this, and his chief of surgery was opposed. So he waited until the chief went on vacation and then ligated this duct and got what for when the chief came back. But it was a great thing to do. So I'm going to talk now about really the start of all heart surgery, which started with children. And this is a story of 4 people and a dog. So this is the first person, Vivian Thomas. Vivian Thomas grew up in Nashville, and he had decided that he wanted to go to medical school and was all set to do that in the fall of 1929 when the stock market crashed. This took the banks, it took his savings. He'd also been working to support himself as a carpenter for his father, who was a general contractor. Well, contracting and carpentry jobs died up too because no one was building anything after the crash. And so his job search took him to the lab of this man, Alfred Blaylock, a surgeon at Vanderbilt at the time. Dr. Vanderbilt's trauma research got him noticed by Johns Hopkins, and he was recruited there. But he said he would only go if he could take Vivian Thomas with him, and Hopkins wisely agreed. So in 1941, Blaylock went to be the chief of surgery at Hopkins. And there they met Helen Taussig, who Dr. Arias mentioned, who was a pediatric cardiologist and had been worrying for some years about the difficult plight of these blue babies and what could we do about them. Well, in the animal lab, and this is Anna. Anna was one of the dogs. Her picture hangs in the rotunda at Hopkins. In the animal lab, Blaylock and Thomas had been working on a model to create pulmonary hypertension, which involved ligating and turning down the subclavian artery and anastomosing it to the right pulmonary artery. And Helen Taussig and all of them thought that this might be a way to increase the pulmonary blood flow for these blue babies. So here's Eileen Saxon. Eileen Saxon is 15 months old, and she weighs 9 pounds. Her heart failure is so bad from being a blue baby that she's basically the weight of a newborn. And they decided if we were ever going to try this on anybody, it might as well be on Eileen. We were out of options. So late in 1944, Blaylock undertook this procedure. Now, Hopkins was segregated at the time, and there was a little kerfuffle at the beginning of the morning about having Vivian Thomas in the room, but Blaylock sort of just crossed his arms and said, I'm not doing this without Vivian Thomas. And so this is Vivian Thomas standing behind Blaylock during the whole procedure. In fact, Thomas was the better surgeon. Thomas had done more of these procedures on dogs, and in fact, he'd even invented some tools like this vascular clamp that could be used in small-sized bodies. Today, Vivian Thomas would have been a cardiac surgeon. So this is the procedure they did. This is a classic Blaylock-Taussig, and we should say Thomas shunt, I think. They took the right subclavian artery and anastomosed it to the pulmonary artery, and this created an additional source of blood flow for these kids. Today, this shunt is alive and well. It's used in many surgical procedures. Instead, this is Gore-Tex. We no longer turn down the subclavian artery. But this was really a shot heard around the world medically. Eileen Saxon went to sleep, and they really didn't even have pediatric anesthesia technique at the time, went to sleep, this moribund blue baby, and woke up a pink pioneer in congenital heart disease. There had been little or no surgery other than maybe try to snatch and grab and repair a knife wound on the battlefield of the heart. It was considered off limits, not anymore. And this is one area where pediatrics has led the way. So my institute, NHLBI, in 1949, the first year that it awarded grants, awarded the princely sum of $11,000 to Alfred Blaylock and his team to continue their work at Hopkins. So what's NHLBI doing for us today? We, of course, accept a lot of grants from investigators, and there's a robust intramural program doing research related to congenital heart disease. But I want to tell you about sort of the major program related to this area that we have. So this is a translational program that includes the Cardiovascular Development Consortium, in which a set of academic researchers are trying to unravel the molecular underpinnings and also the complex transcriptional regulatory networks that underlie the development of normal and abnormal hearts. The Pediatric Cardiac Genomics Consortium is looking at genetic causes and genetic contributions to outcome. They've recruited in about 4 years more than 10,000 kids with congenital heart disease, and in many cases with both of their parents. The Pediatric Heart Network is the oldest member of this consortium. I'm going to talk a little bit more about that momentarily. And together, this is NHLBI's bench to bassinet translational program. So here's the Pediatric Heart Network in 2016. We're 15 years old now. There's 9 main clinical sites, a whole host of auxiliary sites, and we're helped by our data coordinating center, the New England Research Institutes in Boston. Since its founding, the Pediatric Heart Network has conducted more than 20 studies and currently has several ongoing, including a landmark surgical clinical trial that involved 555 infants with hypoplastic left heart syndrome, in which the Blalock-Taussig shunt was randomly compared to a novel approach for infants with single ventricle physiology. The novel approach was associated with fewer deaths and transplants at the end of a year, which was the trial endpoint. Since then, however, that difference has gone away, and so that story is still being told, and the Blalock-Taussig shunt is still pretty much in the mix. So let's go back to Joshua for a minute. Joshua was born at a good time. So the red line is infant mortality per 100,000 live births. The scale is over here, and congenital heart disease infant mortality is the blue line, and the scale's over here. That's per 1,000 live births. And you can see over the past 6 decades, this has come down considerably. And when Joshua was born here in 2000, this was a pretty good place to be born. Most children, even those with complex congenital heart disease, survive infancy, survive childhood, and grow into adulthood these days. I want to say one thing now about the quality of that survival. So kids are surviving now, but it's not an easy life all the time. You've already heard me talk about the number of procedures and the amount of health care that Joshua's had, and think about the impact on his family and other siblings. But also, many children with congenital heart disease have neurodevelopmental disabilities and learning disabilities. So this is work from the Pediatric Cardiac Genomics Consortium, which suggests that a number of these have a genetic cause. There are other potential causes. Open heart surgery and cardiopulmonary bypass causes the activation of inflammatory mediators, which is not so good for your brain. Many of these kids, like Joshua, are cyanotic or blue for the first few years of life. That's not good for your brain. The abnormal plumbing may lead to abnormal blood flow to the brain, which also may not be good. But here we see a genetic explanation as well. So I am not a geneticist. I am not going to go into this in detail. Please don't ask me any questions about this. But basically, these are genes, genes expressed in heart development and genes expressed in brain development. And what we see here in the upper quartile is these genes traveling together, suggesting that the same mutations that are associated with congenital heart disease are also associated with neurodevelopmental defects. So there may be a genetic underpinning to all of this. This may help us not so much treat children, but identify those who may be at the highest risk. So what about costs? So I don't know if this is to scale, but there's about 85 times as much heart disease in adults as in children. And yet, if you look at the hospital costs alone, never mind the societal costs, the costs of early death, the opportunity costs, cost of families, just the hospital costs are only 12 times as high for adult heart disease as pediatric. So there's a very disproportionate cost burden related to congenital heart disease. And Joshua's care so far, just his hospital care for cardiology, not his lip, not his cleft palate, is $500,000. And again, he's only 15 years old. So I'm going to spend 2 more slides on some potential future strategies. So stem cells have been used largely in cardiology, sorry. Stem cells have been used primarily in adults to treat ischemic heart disease, Can we bring stem cells to bear on the scar and improve function in that area? But stem cells may also be able to be used in children. And you can get stem cells. You can get stem cells generated from the fetus, from the umbilical cord blood at birth, and during surgeries after birth, you can get tissue from the heart to generate stem cells. Here in this slide, what they're showing is using those stem cells as well as some graft material to put shunts and other things in children which can grow with them. So surgery is great. Surgery is life-saving, but synthetic material doesn't grow with the child. And surgery causes scarring and arrhythmias and can cause cardiac dysfunction over time. So it would be nice if we could put something in a child that was more natural, so to speak, and would grow with them. But another potential use of stem cell therapy is in children with hypoplastic left heart syndrome. So this is really the first trial of stem cell therapy. This was delivered by a coronary artery catheter infusion of cardiac progenitor cells. So children with hypoplastic left heart syndrome, 7 of them, who were undergoing their second or third phase of surgery. At the time of surgery, cells were harvested from cardiac tissue. They were grown up, and about 30 days after the surgery, they were infused. And there were 7 control children. So the controls are in black and the treated children are in red. Ejection fraction is one measure of how well the heart's squeezing with every heartbeat. In the control children, over the 18 months during which they were followed, there was no change, no improvement in ejection fraction, and this ejection fraction isn't so hot here. In the treated children, however, the ejection fraction went up significantly. These p-values all have a lot of zeros after the decimal point, which illustrates significance. And another thing in congenital heart disease is the kids are always small. And so the control children here, their growth did not change over these 18 months, which is sort of sad if you think about it. They're supposed to grow in 18 months. These are kids who are 3, 4, 5, 6 years old. However, the treated children did grow over this period of time. So 7 children treated does not tell us that we can change to this therapy. It's also a complex therapy, but this is something to think about for the future. And so I'd like to now introduce my colleague, Laura Olivieri, who was caught in traffic. Laura is an assistant professor at Children's Hospital and is doing some wonderful work with advanced imaging and 3D printing. And she hasn't brought a patient, but she's brought a heart with her. So thank you. She and I will take questions together.
Gail, that was wonderful. I didn't know if I could get some help hooking up my computer.
Oh, okay.
Give me a few moments. I'm going to give you a thumbs up when I get to the back, and then you'll be active, okay? So just give me 1 second.
Okay.
Give me 1 second.
You might have seen Laura's work in the Washington Post about 1.5 years ago when they did a piece on her and her work with 3D printing of hearts. Laura was once my fellow, so I take full credit for every single thing she's accomplished.
Thanks, Gail. Yeah, I apologize. I was a little late. I was imaging one of our children down at Children's before I came up here. And that's really what I'm about to tell you anyway, is that the imaging work is, oh, I'm sorry. Can you not hear?
Yeah, they can hear you.
Oh, okay.
Just speak.
I'll just speak louder. Imaging is a team sport, and the 3D printing that we do, it's all teamwork, honestly. Thank you very much. That was very fast. So thank you, and thanks for the opportunity to speak to all of you today. I appreciate it. So My talk is very brief. I was hoping to just kind of review some progress that has been made by all of us who do cardiovascular imaging, briefly describe the 3D printing workflow from taking a picture to printing out a heart, and then discuss some clinical applications of these printed hearts. So as Gail very nicely described, kind of the scope of our problem here, congenital heart disease is common. There are many defects, and within each defect, there's a wide spectrum of severity. Clinical decisions for patients with congenital heart disease are made largely on how the heart appears on imaging. So imaging is really, I would say, now I am a cardiac imager, so you can take this with a grain of salt, but I think imaging is of paramount importance in making decisions for your patients, and in studying congenital heart disease and trying to improve outcomes in our overall patient population. And so what we have are patients who require a fair amount of care, and each aspect of their care is a bit complicated. So they require kind of extensive cardiac imaging and often special 3D imaging. They often require procedures. So procedures can be in the cardiac catheterization lab or in the operating room. They require expert intraoperative anesthetic care as well as postoperative ICU cares. What this all boils down to is, I believe they need individualized, specialized care. And so maybe we could just back up a moment and talk a little bit more about what Gail kind of introduced in her talk. The foundation of how we think of all congenital heart disease, the whole classification system, is derived from pathology specimens. This may seem obvious, but I think we need to think about that 60 years ago, the children that we treat every day, their heart disease was lethal. And the way people described it and came up with classification schemes was by doing what is being done in this picture, directly inspecting a pathology specimen, looking inside, looking at the different features, and basically holding a heart in your hand and figuring out what was wrong with that heart in a very specific way. I do just want to draw everyone's attention, if you want further reading on the subject of cardiac development, this reference here on the right, the black and white photo was work done by Prita Danawantwari, collaborating with investigators here in the, I believe, intramural NHLBI. Was published in Circulation '09. This is an outstanding paper. She was able to image fetuses between 6 and about 9.5 weeks, and went through and kind of confirmed a lot of our suspicions as a community about heart looping, heart septation, all kind of development of the human heart. Now, I think that article is fascinating, so I recommend it for further reading. Okay, so we'll talk about imaging. So ultrasound. This is our mainstay of imaging. Ultrasound's easy, it's cheap. There's no long-term effects of ultrasound. Doesn't require sedation, doesn't require an IV. Has excellent temporal resolution, i.e., how quickly pictures can be repeated to create a movie of the cardiac cycle. It has excellent spatial resolution. We can image people our size, adults, and my colleagues in fetal medicine can use a special probe and image a fetus at 12 weeks gestation and determine if they have 4 chambers and 2 crossing outflows. We can also see blood flow as depicted in this movie here. We can see septal defects, we can see valve leak. Echo is great, but frankly, congenital heart disease occurs in 3 dimensions, and we really need to understand the relationships of each of the different features of the defect to each other. So enter magnetic resonance imaging. This is a series of kind of a continuous series of cine images from a 2.5 kilo infant that was done down at Children's at the beginning of our combined project. This is work that Michael Hansen, Adrian Campbell, Tony Faranish, and others in NHLBI collaborate with us in order to accomplish. So cardiac magnetic resonance imaging is exciting because it is the spatial and temporal resolution. They aren't what echo can do, but they certainly are getting there. And the value added here really is that we can see defects in 3 dimensions. With the use of a little bit of IV contrast, we can get beautiful angiograms with isotropic resolution, such as this one. This is a 4-kilo child that was done in our institution, has a double aortic arch. This child, because of this angiogram, was able to avoid having a more invasive test, such as a cardiac catheterization. So I was showing this to someone at my institution, Peter Kim, who heads up our Institute for Surgical Excellence, and he asked me, "Do you think you could print that?" And I said, "Maybe, I don't know." So 3D printing. I think a lot of people, certainly if you read the any news, lay press news outlet, you've seen articles on 3D printing and 3D printing in health. It seems like everyone's interested in 3D printing. In 2006, there have been more kind of scientific papers describing the use of 3D printing to display structural heart defects. I think it's interesting to look at how the models have changed over the years. This is like 06, 07, and 08, these publications. My lab downtown at Children's National is very focused on printing actually from echo, but certainly any 3D imaging modality can then be used to make a 3D segmentation, which can be printed out if that is, if necessary. So this kind of the state of where we are right now with 3D modeling, 3D printing in 2016. 3D printers are more accurate and affordable than ever before. You can go on Amazon tonight and order a MakerBot for $500 and have it shipped to your house in 2 days if you want. 3D segmentation software, there are a ton of these. Some are free, some are extremely expensive, but most of them allow for really easy segmentation of very complex shapes like the heart. And we are at a kind of a really nice period of time where we can really do beautiful three-dimensional imaging using MR, CT, or echo of structural heart defects, particularly in infants because they image so well. So the process of segmentation, for those who are not familiar with it, is basically a 3D data set is obtained. So you can picture it like a 3D block of data. And what segmentation is going through and selecting voxels, which is the three-dimensional pixel, selecting voxels for inclusion and voxels for exclusion in an eventual digital model. So panel B represents, like, as you go slice by slice and include and exclude voxels of data, you create this model of the heart. That digital model can kind of be refined and post-processed and then printed out on the printer as depicted in panel C down there at the bottom. So how do these heart models impact care of children with heart disease? They can be used in management decision-making, as I've already alluded to. I have a patient with heart disease X. Should I do surgery A, surgery B, or cath intervention C? Once the management decision is made, they can be used to plan that procedure, and they can be used in postoperative care. So I have a case to show you very briefly. This is a 31-year-old man who came to Children's. He was born with transposition of the great arteries, wherein the pulmonary artery arose from the left ventricle and the aorta arose from the right ventricle. He underwent repair in infancy with the repair that was popular at the time, something called a mustard atrial switch, where pulmonary venous return brought the red blood back to the left atrium, and then it was rerouted over the tricuspid valve and then out the aorta. And then blue blood came back from the SVC and IVC back to the right atrium. That was routed over to the mitral valve and out the pulmonary artery to reestablish circulation in series rather than in parallel. He had a known late complication of the mustard procedure, something called pulmonary venous baffle obstruction, where basically the red blood comes into the back of the heart, has a tough time getting over to the tricuspid valve, and needed an intervention for this. So he underwent a cardiac CT to plan to kind of understand his anatomy a little bit better. He had a CT because he had a pacemaker, so couldn't have an MR, and had a model printed out based off of this imaging data set. Black arrows here indicate the area of stenosis. Our cardiac catheterization doctor was able to kind of hold the heart, understand where the stenosis is, the nature of the stenosis, select a stent, and actually do a kind of a dry run stent angioplasty. He underwent stenting the next week And as this echo picture depicts on the left side, this was a pre-stent angioplasty picture where there's a lot of high velocity signal indicating a lot of stenosis there in the left panel. That's bad. And after the stent placement and relief of stenosis, the flow was low velocity laminar. He had a successful procedure. We have another case of a woman who actually, this is a case that Dr. Lederman worked with physicians down at, and the team down at Children's on, a woman who had, she wasn't born with a ventricular septal defect, but unfortunately developed one as a complication of her severe, yeah. Oh, sure, yeah. Oh, you think, oh, okay, yeah, sure, I'll just, yeah, sure. Oh, great. I'm happy to answer questions if anyone has ones. So anyway, this woman had she had a ventricular septal defect, so a hole between the bottom two chambers of the heart that wasn't supposed to be there. It developed as a result of her severe coronary artery disease, which is a known but rare complication. So she had a hole that was leaking blood from the left ventricle to the right ventricle. She went into severe congestive heart failure because of this, and the hole needed to be closed. She wasn't really an operative candidate, and the hole looks like it would be amenable to closure in the cardiac catheterization lab, which doesn't involve surgery. So she also had a cardiac CT for planning purposes to kind of better understand her individualized version of the ventricular septal defect. Because again, she wasn't born with this, it developed. And when these things develop by this manner, they can kind of develop randomly. So orange arrows here indicate the defect. The left panels and, the right panels and then the top left panel are the CT images, and then the blue is the segmentation. So those were the voxels that were selected into the model. And then that yellow in the bottom right is the digital version of the model that was printed out. Here's a picture of it. I have it here today as well, if anyone wants to see after the talks are done. And so she was taken to the cardiac catheterization laboratory. This is an angiogram. So in the laboratory, this is a catheter that's gone up like down her aorta, down through her aortic valve into her left ventricle, injecting contrast into the left ventricle. And down here, you might be able to see there's some contrast that kind of leaks across here. This is the wall, the interventricular septum, and the holes down here. And over in the right, we have a successful placement of the device in this woman. So, so just another example of how when you have kind of a unique individual problem, I don't know that a 3D model completely makes something that's undoable doable, but it certainly helps, I think, guide the process. So the next direction our lab is going in, I started thinking like, yeah, we can print these heart models, we can make them and we can print them out. I don't know how important it is to print them out. So we actually developed a tablet-based application where people can kind of go and have their own primary experience with the digital model. So it's a tablet, you can zoom in, zoom out, rotate it, go inside, look around. There's the ability to label, measure, and everything, anything you would want on an app like that. And what we're doing with these is actually when patients have their cardiac surgeries and come back to our cardiac ICU postoperatively, we create like a specialized tablet for that patient and put it in their room. And this is actually one of those tablets. I don't know if you can see it, but one of those tablets in the room. So this is inside the patient's room. This is this patient's care team kind of using the tablet. And we just published this study a few months ago. I'd like, I guess, to draw your attention to 7 and 8, point 7 and 8. So we polled physicians and training nurses. We're at a pretty big teaching hospital. So physicians and training nurses and ancillary staff, and pretty much everyone universally across the board found that these patient-specific digital simulations were enhance their ability to take care of the patient and enhance their ability to hand off what they knew about the patient to the oncoming team, which is, I think, very interesting. I didn't expect to find that much support for this, which was interesting. So what's next? We are trying to organize a trial, basically, of these models, these plastic models on surgical outcomes in very specific types of congenital heart disease. We have 13 pediatric sites comprising most of the major sites in the center that do congenital heart surgery. We've raised a fair amount of money and are continuing to raise money to run this trial to see exactly what the impact of these models is. So I'd like to thank everyone for their attention. Sorry if I spoke fast. Happy to answer questions whenever that's appropriate.
Well, thank you both very much. We have time for a few questions, and anybody have a question that you wish to ask at the moment?
Is your mic still?
Yeah, here.
Nice job. Very nice.
Dr. Pearson,
It's on.
Dr. Pearson, you commented about we can fix the plumbing, but it's the electrical system that there's scar tissue. These surgeries are a little messy. Can you comment on the electrical complications these patients face for the remainder of their lives?
So thinking about the single ventricle patients in particular, because of the amount of surgery they've had in or near the atrium, the right atrium is sort of where conduction starts in the heart. They tend to develop problems with regulating the heartbeat, and they often have either heart rates that are too slow, like Joshua did, or they have abnormal heart rhythms that arise in the atrium or can arise in the ventricle. So a number of patients with congenital heart disease have either heart rates that are too fast or too slow or aren't going in the order that they're supposed to be going, the conduction system.
So I wonder, children or fetuses who are exposed to thalidomide, who developed phocomelia like your patient showed unilaterally, do they have congenital heart disease?
I don't actually know. Do you know? Not that I'm aware of. This syndrome that Joshua had, a Holt-Oram syndrome, is actually, we know in general the transcription factor that's involved, TBX1, I think, and that is associated with a heart defect. We haven't looked at that in Joshua.
But is that associated with a central nervous system
Can be.
defect? It can be. I see. Yes, here.
With the imaging,
It's on,
the imaging that you guys are doing, reconstructing
I think.
3D, are you able to, more than just, I guess, print and surgically plan something, I guess, for example, you place the device, correct that defect?
Can you actually correct the defect? Can you develop devices that are patient-specific? So is there a benefit to that, or has there been shown any benefit to building patient-specific devices from these 3D models? Or I guess there's also like compensation after you perform some of these surgeries. There must be some sort of biological compensation that occurs. Can 3D models potentially help you in terms of surgical planning so that those compensations can somewhat be beneficial or less? You said like the development of that shunt formation. Is there ways to prevent that with prior surgeries that could be corrected via 3D modeling or something like that?
I think it's a great question. So Ajit Yoganathan down at Georgia Tech does actually a fair amount of work of simulating hemodynamics based on the shape of patient, so in a patient-specific manner based off of patient imaging of how, kind of how to optimize either a surgery that's not worked out well or even optimize someone going into a surgery that everyone knows is going to be difficult. And he has a kind of a surgical planning suite down there and has worked with a fair amount of surgeons on specific and difficult cases. Other centers have done that as well. I think he's the one that comes to my mind the most.
Yeah.
And in terms of making patient-specific devices and such, I think there's a lot of interest in this area right now. I know there's a surgeon that we are kind of collaborating with on through a different aspect of 3D printing in medicine, which is 3D printing conduits, basically. So specific ways to get blood from the right ventricle out to an unusual pattern of pulmonary arteries. So making, like an acellular matrix, printing cells in there, coming up with kind of along the lines of what you were talking about too, Gail. So it's a hot topic.
You mentioned surgery to directly connect the vena cava to the pulmonary arteries. It's hard for me to understand how the blood can come directly without the pumping from the right ventricle. Thank you.
Basically, there's a transpulmonary gradient that's generated by the mechanical factors associated with beating, and to some extent, the cycles of the heart itself. That's about 8 millimeters of mercury, the difference, and that's enough to drive the blood flow across the pulmonary artery vasculature, allow the blood to pick up oxygen and return to the left atrium. It's not a great solution, as you might imagine. Many of these kids in adolescence begin to have decreased exercise tolerance because you can't pump the blood through the lungs fast enough to support exercise.
Have any of the genes that have been associated with congenital heart disease been knocked out in a mouse or something, or create an animal model to look at? Has that happened? Yeah.
Yes, there are a number of different types of animal models. In fact, Bob Edelstein created one accidentally, right? With one of your myosin experiments, created an animal with a double outlet right ventricle. Yes, there have been people looking at animal models of congenital heart disease. A lot.
And when you, sometimes if you're lucky enough to find an associated gene, it's very common then to put it back in the animal from, taking it from the human and showing that you get a similar kind of thing. And sometimes you can do that with mice, which are more expensive, or with even with zebrafish.
Yeah.
So do we know, Bob, with any of those what the mechanism is?
Well, yeah, if we know the genes, we have a good chance of understanding what the mechanism is.
Most of the mechanisms seem to be related to transcription factors that don't work the way they're supposed to. And more recently, some of the work out of the Pediatric Cardiac Genomics Consortium has suggested that histone modifying factors are heavily involved.
Okay, well, thank you very much, and we will probably have time for more questions afterwards. So, Bob?
Do you have a mic?
Getting it fixed in a moment.
Oh, you're going to take
Thank you.
Okay.
Oh, wrong computer. So thanks for having me. I'm an adult cardiologist here in the intramural program at NHLBI, so I'll be switching directions and talking not about molecular development, but about simple plumbing, simple mechanical treatments for structural heart disease, whether it is congenital or adult. And a lot of these treatments have been performed using very simple image guidance, just shadows cast by X-ray beams. And in the last few years, as we've had more advanced imaging capabilities, we've been able to expand the therapeutic possibilities of treatments that don't require surgery. So I'm from the intramural program, and do you like this cute title, transmural? Because these therapies under imaging guidance will be crossing walls. So let's see if you think that's cute. The work in my lab has, I've been fortunate to work with a bunch of really talented clinical and technical people here and abroad and lots of different medical centers, too numerous to count. So let's begin by talking about catheter versus surgical treatment. These are in adults. I'm sorry, this movie doesn't work. On the left, you have a simple catheter treatment of a devastating illness, acute myocardial infarction, where a coronary artery is suddenly blocked. And using very simple and inexpensive catheter tools, if you get there in time, you can blow open the hole, blow open the blockage, restore normal blood flow to the heart if you get there in time. And this is pretty effective and occasionally life-saving. By comparison, another similar mechanical therapy is coronary artery bypass surgery. This is viewed under a zoom lens of a camera inside the chest. It's a robot that's suturing one blood vessel to another. By comparison, the catheter-based treatment uses a tiny hole. And the treatment, the targets that are constrained by anatomy, we're pretty much shoving a tube into another tube or another chamber, whereas surgeons put a big hole in the chest. Their treatments are guided by visualization. And there are pretty much no limits to how much injury a surgeon can expose their patient to in the course of surgical repair. It's an important difference. Here's another comparison. Interventional cardiology is more like plumbing, whereas surgery is more like general contracting. And so the treatments, the tools are more simple and less invasive, therefore less injurious, but by comparison, they also may be less effective. Here's a good comparison. If you want to do some plumbing work, you put a snake in. That may not be so good. A more definitive repair is to blow down the wall in your bathroom and knock down the pipes and replace them definitively. And this is probably a fair comparison. And as a general rule, surgical therapies can be more effective, but they come at a bigger expense of patient injury. So let me give you some examples of congenital heart disease catheter-based non-surgical repairs. These are all given to me by Elena Grant, who trained with Gail and Laura, and fortunately will be returning from Emory University next year to become a grown-up herself. This is a child who has a persistently patent ductus arteriosus. This is an important component of the fetal circulation, wherein the lungs are bypassed in utero. And in this child, for some reason, the ductus arteriosus connecting the pulmonary artery to the aorta has failed to close, and the child has overcirculation as a result, as the normal pulmonary vascular resistance declines in the early postnatal period. So Elena put in a commercial device, a self-expanding nitinol spring that is so groovy it can fit through this tiny tube and be deployed across the hole and then block off that persistently patent ductus arteriosus. This recapitulates that surgery from 1940. It takes about 10 minutes and is not too injurious most of the time. And in this case, pretty effective. Here's another example of a non-surgical treatment, again, courtesy of Elena Grant. This is a child who has a pulmonary valve that is maldeveloped and practically not present. You can see the remnant pulmonary valve. And so blood flow isn't able to connect the right ventricle to the pulmonary circulation. Instead, this child is relying on persistent fetal circulation. And just by poking a little guide wire through where the blood should be flowing, Dr. Grant was able to advance a balloon, again through a tiny, tiny hole, in this case through a neck vein, and restored some rudimentary valve function, but more important, restored antegrade flow. So not a perfect solution because this valve is still leaky, but pretty darn good in a very simple, non-injurious procedure using rudimentary imaging guidance, just X-ray shadows that you see. This is a child who had a tetralogy of Fallot surgical repair, like one of your fancy Olympic athletes, and had a common late sequela of that repair. The child's pulmonary valve is non-functional, and so blood is freely flowing between the right ventricle, pulmonary arteries, and back, and that wastes a lot of the energy of the right ventricle. And using a simple transcatheter implantation of a simple $20,000 device, give or take, this stented valve is able to restore valve function in a non-surgical procedure. And finally, you may have heard of another revolution in adult structural heart disease. That's in the treatment of aortic valve stenosis. In this very common problem of the elderly, although there is another form that's related to congenital heart defects, congenital heart disease. The aortic valve has degenerated and fails to open. This is the valve that connects the left ventricle to the aorta, the principal artery of the whole body. And so this aortic valve is not opening, and it can be repaired very effectively by an open surgical procedure where the chest is open, the heart arrested, the patient put on temporary cardiopulmonary bypass. The patient's usually refrigerated to preserve their brain and vital organs, and that works great if they're young. It turns out this disease is more often manifest among the old and frail who can't all universally tolerate surgery without complications. And so this commercial device that's deployed over a simple balloon, it's again a simple, albeit $35,000 disposable device, is implanted in a catheter procedure and restores normal valve function. And this proves life-saving in what is otherwise fatal disease. That's performed, again, using simple, rudimentary imaging guidance that hasn't changed much in the last 30 years. So to summarize contemporary treatments, we can't see much. We can accomplish quite a bit as long as we stay confined within normal vascular spaces. Wouldn't it be nice if we could see what we're doing? So let me show you some of the progress we've made in our intramural labs. Again, I stand on the shoulders of giants, both within my lab and in other labs across the world. So most of you think of MRI as a fairly slow, low resolution, groovy, noisy, expensive imaging modality that's used in the brain. But Laura showed you a few pictures of MRI of the heart. It turns out you can buy an X-ray lab and sit it next to your MRI lab, and you can transport patients, like this is one of our patients, like the one we treated just today, where we transport them between an X-ray and MRI lab, and we do some of the procedures under MRI. We do that because now we have access to so-called real-time MRI. In real-time MRI, we're able to image multiple frames a second, enough to guide catheter procedures, and then we're also able to take advantage of very sophisticated image acquisition reconstruction techniques to get useful information about how the heart beats, about how much blood flows, and about the tissue composition of the heart tissue itself. To guide catheterization, it's attractive because we can measure blood flow very accurately. We can avoid radiation altogether, and we can take advantage of many different versatile imaging contrasts. So we started doing this about 2 or 3 years ago. This is our first MRI catheterization. We filled a balloon catheter with an MRI contrast agent so that it shows up white like this. And we're steering from one chamber to another, from the femoral vein in the groin, up into the superior vena cava, up from the right ventricle into the pulmonary artery. You have to understand, we're really spinning a noodle that's attached to a balloon and trying to get it to go to the right place. And here we're able to select one or the other pulmonary arteries. Because avoiding radiation is perhaps less important in the adults that I treat, NHLBI installed an intramural MRI cath lab at Laura Oliveri's place at Children's National Medical Center downtown. It's very pretty, like this, and it's otherwise similar. And some of these procedures were introduced into clinical practice by Kanishka Ratnayaka, who has since left us to move to San Diego, and Dr. Elena Grant, whose images I showed you before. You see some really nice movie and then still frames of the same type of catheter technique as the catheters steered from one chamber to another, all entirely without radiation. That's pretty handy, and it's now been applied in about almost 3 dozen patients. That's pretty nice. And while we're in the neighborhood, we can make some really groovy measurements. If there's a heart defect, we can actually see it while we're sampling blood flow in the heart. If the patient has a common unrecognized disease of adulthood, such as chronic thromboembolic pulmonary hypertension, in just about 30 to 60 seconds with a milliliter of MRI contrast agent, we can make a map of blood flow in the lungs while we're in the neighborhood and get a lot of information about the patient, make an important diagnosis. So that's some clinical work. Let me show you some stuff that we're still busy trying to translate from animals into patients. What can we do? Well, one is a biopsy. In patients who have infiltrative or inflammatory heart muscle disease, it's common to want to do what real scientists have done in other disciplines for decades. In oncology, in blood diseases and infections, it's very nice to be able to sample the diseased tissue. In the heart, that's a little more difficult and invasive. And it's interesting to see the making of this sausage that we call cardiology. In patients who have inflammatory disease or for example, need surveillance of a recent heart transplant, we put this jaw through the leg or the neck into the heart under X-ray. Can you tell where we are in the heart? Well, I have a lot of experience doing this. I've done maybe 1,000. I can't really tell either. I know I'm kind of in the right place. And I'm sorry, this is really what we do. We pretty much put the forceps in the heart. We put a little pressure. We spin counterclockwise. And then we close our eyes and hope for the best. And thank God it usually works. But wouldn't it be nice if we could see what we're sampling? So this is some work that's been rejected from some of the best cardiology journals, where despite years of work, we finally made a biopsy forceps that doesn't destroy the image under real-time MRI. Toby Rogers made a model of a cardiomyopathy. He labeled tissue with just some fluorescent microspheres, and comparing MRI biopsy, like you see here, where we can see the target, we can see where we're spinning our catheter, the diagnostic yield of MRI specimens, these are millimeter scale, were superior to X-ray specimens. That's pretty groovy. And in fact, NHLBI is really interested to introduce this into clinical practice for pediatrics. So we're working hard to bring this to clinical use. But it's a pretty big and expensive undertaking. Now, I know you've shown some examples of a so-called cavopulmonary shunt, so also known as a Glenn shunt. Dr. Ratnayaka, a pediatric cardiologist who I mentioned already, had worked for some time to accomplish this without surgery. This is part of the staged surgical repair of a single ventricle, single left ventricle disease. And the connection is that we're trying to make is between the superior vena cava and the nearby right pulmonary artery. Can everyone kind of make out that anatomy, that geometry? I know it doesn't sound like a big deal, but there are some critical structures in between the two. This is a pig, and here's one structure that we don't want to stick by accident. That's the aorta. So Dr. Ratnayaka is sticking a needle from the superior vena cava into the pulmonary artery, establishing continuity between the two, using a specially designed endograft that doesn't require surgery to connect two different blood vessels, and accomplishing this cavopulmonary shunt. And here we see a nice artificially colored follow-up picture. It works pretty darn well. It works so well that, in fact, we're going to try to use this to reduce the number of major cardiac surgery procedures in children under Dr. Ratnayaka's hands, now that he's in San Diego. So there was a question earlier about rhythm disorders and congenital heart disease. Adult cardiologists are really terminally differentiated, and I really am differentiated into plumbing, not electricity. But that never stopped me from having an opinion. And so we started to see that there might be some opportunities to use this great imaging tool, MRI, to guide treatment of electrical disorders. So this is an example of contemporary treatment of electrical disorders, more commonly in adults than children. But children sometimes have a chaotic rhythm, adults sometimes have chaotic rhythm of the atria that may originate from some place, like the pulmonary veins. And so using very fancy and expensive tools, electricians put catheters in different parts of the heart, and then use an electrosurgery pencil. They essentially burn the heart muscle, and they try to accomplish a line of electrical discontinuity. They're trying to electrically disconnect whole sections of the heart from another. And the problem is that they're burning heart muscle. They can't really see the muscle that they burn. They just keep testing multi-channel electrograms like this before and after burning. And then they see if there's evidence of electrical connection. And since they can't see what they've burned, they burn some more. And then after that, they see they're not yet successful, so they burn some more. And these are very smart, highly trained people, and the diseases that they're treating can be quite disabling, sometimes even life-threatening. But they're just paralyzed by not having good imaging tools. So we thought we would. Here, I'm sorry. Let me show you a good example of what they do. This is a common radiofrequency ablation catheter where they burn heart muscle, and it causes local resistive heating. And there's some injury to the heart that's irreversible. There's also surrounding penumbra of injury to the heart that's probably reversible. It's like getting a blister that heals. So the patients may leave the lab without the abnormal heart rhythm, but then in the weeks or months afterwards, as the injury heals, the rhythm abnormality may come back. So this is some work that we did just in animals. We figured, why don't we watch as we destroy heart tissue? Instead of using radiofrequency energy, why don't we use some caustic agent? And so we're able to mix an MRI contrast agent with one of two caustic agents. The one that works best is vinegar. I know it's, as Dr. Jonathan Hill used to call, prohibitively inexpensive, but it's pretty effective. What's nice about doing this under imaging guidance is that you can see the distribution of heart muscle that you're burning. And you can establish geometric continuity and assume or prove that it's associated with electrical continuity. So this is a nice example. And we learned that we can make beautifully circumscribed lesions with vinegar as opposed to booze. And we were able to make an animal model simulating ventricular tachycardia, a life-threatening rhythm disorder, and ablating the so-called critical isthmus that you see here, this purple bridge, using chemoablation. So stay tuned with this kind of solution that I think really has the potential to make an impact in the treatment of rhythm disorders, both for adults and kids. So I don't want to spend too much time, but I want to show you just one or two really groovy procedures before I stand down. Is that okay? I showed you some potential therapeutic opportunities using imaging guidance using MRI. But let me show you some stuff we've done using just plain old X-ray. One thing that I'm really proud of is something that we call transcaval access to the aorta. I showed you earlier transcatheter aortic valve replacement, wherein through the femoral artery, we put a gigantic appliance and up into the heart, and that's really great and groovy. The problem is that a large minority of patients, usually smaller women or people with diseased arteries and legs, aren't eligible for non-surgical aortic valve replacement. So we thought, why don't we try something a little different? We noticed that there are patients who have a rupture in the artery in their leg that's not fatal. It causes a little bleeding. It can be really bad, but when that rupture spontaneously bleeds into the vein, those patients tolerate the bleeding just fine. So we thought we would simulate that very same problem by poking a hole from the vein, a very nice compliant vessel, into the adjoining artery and introduce our tube in the middle of the body under remote control to introduce our appliance. We call that transcaval access. And it was really rejected as counterintuitive and ridiculous and crazy and dangerous. But it's been now used in about 180 patients at over 24 centers. And let me just show you a little bit of how it works. We use simple catheter tools and X-ray guidance to put a bullseye in the aorta. We burn across from the vein to the artery and put our big tube in. And afterwards, we close it using a tool designed to close a hole in the heart that I showed you earlier. It's long been thought that if you make a hole in the aorta, that the patient's going to die. It's going to bleed to death in about a second. And we believe that because a lot of surgical trainees over the years have taken care of patients suffering horrendous trauma. And in that trauma, the surgeon has exposed the retroperitoneal space. That's the space behind the guts that contains the large vessels in the spine. And in all those patients, when there was a hole in the aorta, the patient just bled to death right in front of them. There's almost nothing that could be done. What's interesting is that if you're not doing surgery, the retroperitoneal space is intact. And if there's a hole in the aorta, the retroperitoneal space behaves as a relatively confined space and pressurizes. And as long as there's a matching hole in the vein opposite the aorta, there is a phenomenon of venous decompression. And so this bleeding can be tolerated. Let me give you an example. This is the 55th patient to have this procedure at a hospital in Detroit where I've been working to bring this into clinical practice. This is a patient who needed transcatheter aortic valve replacement, but whose leg arteries were simply too small. And so we use a technique that I mentioned to put a tube from the vein into the aorta, and then the transcatheter aortic valve replacement procedure went fine. A trainee was being taught how to put the closure device in, and we cautioned him, "Oh, that's good. Don't pull any harder. Don't pull any harder." But he pulled harder. In fact, he pulled so hard that the closure device was pulled all the way out. And so now we had an unconstrained hole between the aorta through the open retroperitoneal space, through the retroperitoneal space into the vein. And here you see it. But without too much difficulty, we were able to recross and close that. And the patient did fine, although, as you can see, there's a residual small arteriovenous fistula. And that patient did great. There's a follow-up CT showing complete healing after a month. This type of technology has been really useful and is being applied now to put in temporary heart pumps, a gigantic device that can't be introduced into the body without surgery, and we've been able to take advantage of this technique. So I have a bunch of other x-ray procedures, but I can see that it's getting dark outside, and people in this room may not want to see me belabor these points. Are there questions you'd like to answer instead? Yes. Let's bring you a microphone. How about this one?
Okay. So do those fistulas eventually close up or heal in some way so they're not spurting blood in small quantities?
So in this case, these iatrogenic, these physician-created fistulas that aren't really good for you, they do close up when we survey them. They turn out not to be, to our surprise, they turn out not to be that medically important. But we have some experience from other diseases. Patients with chronic kidney disease often have an iatrogenic fistula created in their arm to serve as an access site for hemodialysis, and those tend to be very well tolerated. But the amazing thing is, irrespective of this accidental connection between the left and right circulations, these patients seem to tolerate it just fine. And in an autopsy experience, if we look at one of the space between the aorta and cava, it's generally nothing. It's pretty amazing that patients, even patients who are 80, 90 years old, are so resilient they're able to tolerate this injury, which admittedly is not as bad as the injury created by surgical access. Okay. Yes, sir. I'll repeat the question.
Can you please use the microphone?
Do you see any changes in limb perfusion when you introduce these shunts at the beginning of the procedure? Like, I'm assuming some people might have like peripheral artery disease in the lower limbs or something like that that may be exacerbated by a shunt, or is that something that's been looked at?
So the question is, do we cause limb ischemia by working on people, or malperfusion syndromes? And for many advanced procedures that are being offered to patients, for example, with cardiogenic shock, they may have a temporary heart pump put in or temporary cardiopulmonary bypass system put into them. And those patients indeed suffer limb ischemia, and they may survive, but they may not be able to walk out of the hospital. They may need to hop out of the hospital because they'll have literally limb loss related to these devices. So indeed, using this kind of transcaval access approach is one pretty neat way to avoid limb ischemia. But it's also interesting that patients tend to be very resilient. You can do an awful lot to them, whether they're children or adults. You can interrupt perfusion to a limb or a whole half of their body for a few minutes, or perhaps even longer in the course of a therapeutic procedure when they're lying down, relaxed, or sometimes even put to sleep using general anesthesia. So those perturbations can be pretty well tolerated. Does that answer your question?
What do you see as, looking in the crystal ball, what do you see as the challenge and the future of non-surgical treatment of heart disease, be it pediatric or adult or whatever? Do you see something, what's over the horizon? Do you see?
Yeah, so the question is, what are some future therapies in catheter-based treatment disease? There are lots of more specific diseases that can be treated by miniaturized or temporarily miniaturizable devices. Valves can be repaired that haven't been repaired so far, leaky mitral valves. Valves could be replaced in stages using mechanical techniques and catheter techniques. Dr. Oliveri mentioned, and also Dr. Pearson mentioned, various approaches to biologic therapy introduced using mechanical techniques to help regenerate dysfunctional myocardium or infarcted myocardium, or perhaps to help facilitate the replacement of artificial membranes or conduits with cells to achieve arterialization. I personally, in my lab, had a going out of biologics sale about 10 years ago, because I thought I, as a physician, had very little to add apart from acting as a mailman to deliver stuff to the heart. And I think our level of understanding has not really advanced to the stage of plausible therapeutics, in my humble opinion. So I don't regret that decision I made 10 years ago. One of the challenges we're going to face, however, is financial. You see these temporary disposable devices costing tens and soon hundreds of thousands of dollars can be applied like water and can be imminently life-saving. So I see real challenges in how we're going to be able to offer care to patients in need unless we find ways to make these things more affordable. And in fact, maybe advanced technology or biological therapies can help achieve some some reduction in these fantastic costs that we're enduring.
What do you see in terms of fetal surgery for congenital heart disease?
So you asked me about this earlier. What is the role of fetal surgery in congenital heart disease? The most famous work out of Children's Hospital Boston has attempted to alter the inexorably horrendous natural history of certain congenital heart diseases by, for example, treating aortic valve stenosis in utero using catheter techniques. And unfortunately, the results are really muddy. It's not clear that they've succeeded in their early goal. These children don't necessarily have an excellent outcome, and it's been interesting that they've been able to enhance the armamentarium of available tools, perhaps not necessarily benefiting individual children. Everyone remains very excited about these therapeutic options, and perhaps as we have better tools or better imaging tools, we might have a more encouraging report. Do you think, Dr. Pearson, what I said is fair? Would you like to expound on that? I think you should.
I don't know if I have a lot to expand, but you know, as I mentioned, in 1944, people thought heart surgery was completely off limits. So now we sort of think of the fetus as being off limits in a way. And also fetal procedures have the potential for 200% mortality if something goes wrong. So that's something you'd want to undertake lightly. But I could envision the potential for stem cells in the fetus maybe, or for things that could be implanted that grow. Now, again, the heart forms by 8 weeks. We're not going to really, unless we can somehow work on molecular switches while the heart is developing, that might be 50 years down the pike, we're not going to really influence the heart. But there are some things that do get worse in utero that maybe we could have some role in. At the moment, the main thing we can treat in utero is fetal arrhythmias by giving the mom so much medicine it makes the adult cardiologist nervous enough so that the medicine crosses to the fetus. This is often very effective. These are, of course, rare conditions. But I think there's reason to be cautious, but also maybe reason to press ahead because we don't really know where the next frontier is.
Are there other questions? Yes, here.
I just want to ask maybe for really any of you, but what do you see as the next frontier in adult congenital heart treatment and, you know, perhaps either at a surgical or you know, immunological transplantation or, you know, I mean, there's even xenograft talk now. You know, what do you see as the next breakthroughs in adult congenital therapies?
I'll venture just one response. The Fontan circulation that was introduced to you, where patients have are enabled to survive beyond childhood by replacing the right ventricle as an active pump with just a passive conduit. The venous circulation connected just to the pulmonary circulation. There was a question, how can that possibly work? Exactly, how can that possibly work? And it doesn't work so well. I think there's a huge unmet need. Now you've asked for a solution and a frontier. I've reiterated a problem. It's a fascinating problem, and there are a lot of phenomena that can be exploited to enhance the Fontan pump. Perhaps it would be the respiratory mechanics system. Perhaps it would be neighboring intrinsic pumps. Maybe it'd be extrinsic pumps.
Maybe it would be pumps that you place under MRI guidance with a catheter.
And then take lots of pretty pictures of.
That's right.
Yeah. I think whatever it is, I mean, not to keep tooting the imaging horn, but I think the interesting thing about adults with congenital heart disease, particularly with complex defects, people born 20 or 30 or 40 years ago with the same congenital heart defect could have any one of a number of have had a number of surgeries, and so I don't know that there's necessarily one solution on the horizon, and so I think it does come back in some sense to individualized, like tailored plans to improve circulation, because really it's the other end organs that suffer the most.
And I think the work that Laura and Robert are doing is going to create a new generation of adults with congenital heart disease who are in much better shape than the current generation. I think we've made a mistake as clinicians collectively too by restricting people with congenital heart disease from exercising. So it's pretty clear that if you can keep exercising to some extent and keep fit, it's probably better for you, and it's certainly reasonably safe. So one of the issues that adults have is they decreased exercise tolerance. And I think we also need to understand better the effects, as Laura alluded to, of the Fontan circulation and other complex, unnatural circulations on other organs, particularly like the liver. Most adults with the Fontan circulation have liver disease. And we don't really know why. We can guess why, but we don't really know what to do about it.
Fix the heart.
Fix the heart, yep, we've thought of that.
All right, well, listen, thank you very, very much to the three of you. That was very exciting.